Hi, dear friends. Today we will talk on chapter 4 of this myopia progression control course. This is mainly about atropine and myopia control, how atropine is used to control the progression of myopia, what is its current status, what are the concentrations in which these eye drops are available presently in India, what holds promise, and we will talk about the safety profile of atropine, our own work on atropine, what we have been doing since last 8 to 10 years on low concentration atropine. We will also talk about how it has evolved, how it has progressed, and how it has become one of the one of the cornerstones of reducing the progression in myopia. Atropine has been there, atropine has been around almost since last 50 years, and there has been a lot of work on atropine, a lot of interest on atropine. uh, there has been work done in the past, and now they are talking a lot about concentrations, they are talking a lot about delivery systems, they are talking a lot about how the actual penetration occurs, and whether what are the theories as to how this low dose atropine or low concentration atropine starting from 0.01%, as low as 0.01% to as high as 1% has been used in our country, across our country, and in especially in Asian countries. So I think we'll start with uh, what is already known in myopia. So we all know that this has been talked in the first lecture on how myopia progression occurs, what are the risk factors of myopia. Some of the articles were shared, some of the articles were discussed as how and why myopia progresses. This was just a take on how myopia progress. And to start with, you know, how atropine has come into practice. So sometimes, when we talk about atropine, or when we talk or discuss atropine, we feel that it is a pretty new phenomena. But way back in 66, again followed by Gimbel et al. In 73, 84, 89, and as recent as 2000, 2001, there have been retrospective data on atropine 1% or scopolamine eye drops, or even as recent as 2000 and 2001, when Shi et al. They did some work on reduced concentrations. And before atom studies, there were RCTs of almost 1.5 years. You can see an RCT of almost 8 years long, but this was in untreated myopes. And sorry, this was not in untreated myopes. The control group was untreated myopes. And there have been a lot of literature on what went on uh, even prior to atom studies. Uh, you can see a very good study in 2006. Obviously, it was non-randomized studies, but you can see that they used a 0.05% atropine eye drops even before the landmark study, Atom 1 study, the study on Chua et al. Now, what this particular data doesn't tell about Atom 1, we will see in the next slide. But what I'm trying to say is that it has been a long time since atropine has been used. Atropine is there, and even low concentration atropine has been there. Way back in 2006, there is an article where they have suggested that they used, although it was a non-randomized study, but they did it just to show. And importantly, we should see that they were not really measuring the change in axial length. So bulk of the work was actually the thought process was based on the fact that it is the accommodation which is responsible for the way atropine is working. So I think that is the point at which a lot of people left interest, because most of the times it was near work or accommodation, or excessive near work leading to excessive accommodative spasm, and that particular accommodative spasm was being relaxed by atropine, and so the thought process of reducing the concentration was not much active at that point of time. And so the thought that it was actually creating a change in axial length was also not there. And it was only by I think Shi et al. In 2001, and Chua et al., where they suggested that there was indeed a difference in axial elongation also. So they did notice what was the change in refractive error in treatment versus control group, and what was the change in axial length. Uh, so this we start with atom one study, because I think we have to start at some point from where the whole work or whole cascading effect of low concentration atropine started. So before we talk about atom 1, atom 2, lamp 1, 2, 3, and 4 studies, we should also know about what are the biological mechanisms which have been proposed for atropine control of myopia. So we all know that atropine is a non-selective muscarinic antagonist, starting from M1 to M2, M3, M4 receptors, and it is a antagonist of these receptors, and it has been observed that it can reduce accommodation, and it affects dopamine neurotransmitter release from cellular stores. And this is a wonderful article, and I can share it on the WhatsApp group. This article talks a lot on what are the recept at the receptor level, what happens, and how atropine releases dopamine in chick retina, where dopamine regulates the ocular growth, and it is also known to work on GABAergic signaling, and which has in the anti-myopia effect on atropine in mouse eyes. Also, there is some role which they are suggesting that it has some role in inhibition of myopia progression at the scleral site also, and atropine does decrease scleral fibroblasts in vitro at least, and it also increased the thickness of scleral fibrous layers. It has reduced extracellular matrix production by decreasing aminoglycans in the sclera. At the level of choroid, we also now know that choroid does modulates its thickness mechanistically to adjust the retina to be on the focal plane of the eye. Now we all know that the choroid is thin in myopic eyes, and also the fact that as the myopia progresses and axial length increases, the choroid tends to thin further, and it has also been noted that choroidal thickness often reduces or often precedes the changes in the choroidal thickness often precede before the actual axial eye growth takes place. So yes, there have been a lot of work now on choroidal thickness. When the retina experiences hyperopic defocus, the light focuses behind the retina towards the choroid. It is thought to be a signal for eye growth, and the choroid tends to become slightly thin, in a way to give way to the retina, to adjust the retina on the focal plane. And this thinning might allow the retina to move back further, and that may contribute to axial elongation. Now, this is all very hypothetical, but this is what can happen. And so atropine does induce transient choroidal thickness, at least in LIM models, which are lens-induced myopia models of chicks. And atropine also eliminated choroidal thinning, which was induced by hyperopic defocus signals in myopic human eyes without changing baseline choroidal thickness. So there have been multiple theories around with atropine on the working on the sclera, working on the retina, releasing dopamine, or working directly on the scleral fibroblasts, or working directly on choroidal thinning and reducing or eliminating the choroidal thinning, thereby improving the choroidal thickness, thereby reducing the axial growth. And I think most of the other modalities like optical peripheral defocus, or low level red light therapy, or orthokeratology also works via certain of these mechanisms. This is just in a nutshell what has been known about the unclear mechanism of action. So it may be working through multiple M1, M2, M3, M4 muscarinic receptors, dopamine receptors in the retina, alpha-2 adrenergic receptors, which are also found in human retina. They may be regulating dopamine synthesis, which may impact ocular elongation or release of dopamine. And GABA receptors, we already saw cytokine receptors. Atropine also may affect these cytokine receptors, which may be working on inflammatory and signaling pathways, the which are mediated by cytokines. So that may be affected. We already talked about scleral involvement. So at this point of time, a lot of work on which particular pathway or which particular organ system or which particular layer of the eye atropine is working. It is not exactly known, but it has also been talked about that there may be multimodal action, and we will talk also about how we will also talk about how atropine may also affect lens thickness. Now we already know that atropine as a atropine does affect lens thickness by blocking the accommodation, and we know that once the accommodation is blocked, what happens to the lens is that it cannot move anteriorly, thereby nullifying accommodation. However, the change in lens thickness, if you see lens thickness, it's very difficult to measure the optimal change in lens thickness. And there have been certain data by Saxena et al. Where they suggested that the change due to low concentration atropine was around 0.03 at 1 year. And Havid and Hansen Havid Hansen et al. Also suggested that low concentration atropine induces certain changes, and lens thickness became thinner by 0.02 millimeter. However, there is a the and so what they did was that once they have this lens thickness, they tried to calculate the lens power using Bennett formula, and they found that lens power was significantly changed because of the small lens thickness change. Now the lens thickness change obviously was not much, and even by Dr. Rohit Saxena et al. Reported a change of 0.03 millimeters, and Havid Hansen reported a difference of 0.02 millimeters. Now the difference between these two studies is that whereas Saxena et al. Used a 0.01% atropine and Havid Hansen used a different approach. They compared placebo, also was compared, Saxena et al. Also compared with placebo. But these people, what they did was they compared placebo with low dose atropine for 2 years and low dose atropine, but there was a loading dose used for first 6 months of 0.1%. And they found that when you use a loading dose, only then there was a change which was significant. But if you use it, but the difference between lens thickness between 0.01% and placebo group was not statistically really significant. So if you see the difference at 3 month change in placebo was 0.1 in axial length, and in lens thickness it was 0.01, very similar to low dose atropine and similar to 0.1%. So 0.01% did not change much in Havid and Hansen study. Both the studies used IOL Master 700, although the patient population and ethnicity was different. Also, it is very important to understand when we talk about lens thickness and lens power is that these are physiological changes. There may be physiological changes which may be induced when the patient is looking for near or distance, depending on whether this particular effect was calculated using cycloplagia or not. Now you cannot use cycloplagia because once you use cycloplagia, it will become the same. So you want to find out what is the effect of 0.01% atropine, and you truly cannot use a cycloplegic agent to find out its difference because it will not be different. So this was in 2023, and so this particular study, I think following this, there was this particular study, which I think is better than the existing data suggested both by Havid Hansen and Saxena et al. Because what they did was they suggested that lens thickness changes do not occur much, but they found a small shift in lens position. And once you try to put them under accommodation, under physiological accommodation, you could find that there was a small change as per this particular article by Hughes et al. And this is their data. So now what you have to see is that this is the lens thickness. You can see that lens thickness pre and post. There is a small change in children and adolescent. In fact, the lens thickness has slightly increased. But when you go to young adults, it shows that it is almost equivocal and almost equivocal here also. But if you ask this particular patient to start accommodating, you will see that the lens thickness was slightly, see there is a small increase, 0.03 millimeter of lens thickness increase, and a very small increase here, and a very small increase here. But the moment you start telling them to accommodate, you can see that there is definitely a difference, not at 2 diopters, but at 4 diopters and at 6 diopters, and you can see a similar reduction in the amount of accommodation that was taking place. They were, the lens was not able to, the when once you ask the patient to accommodate, the lens thickness did not change much. I mean, it did not increase much as it should, because once you try to look for near, once you induce an accommodation, the lens thickness should increase, but it was not able to increase. So the point which this particular study was trying to make was that the antechamber depth also did not change much, or rather, the lens was not able to move forward as much. Once you induce an accommodation, you're suppose that there will be a change in the antechamber depth, which was also not there much with or without. But once you induce an accommodation, you could see that patient was not able to accommodate. So the point out of all this confusion, which these three papers are trying to make, is that there could be, this could be one of the reasons how atropine induces its effect, which is more than the change in axial length. So even if you see all the studies of atom 1, 2, lamp 1, 2, 3, 4, and even in our own clinical work, we sometimes find that axial length has not changed much, but the power has not increased much, but axial length has increased. So the correlation between axial length and power sometimes does not come in patients who are on atropine. So the point which we are trying to make here is that there is a chance that atropine does work by by their effect on lens thickness, and it is actually the lens thickness which reduces little bit, and that is partially also one of the reasons how the mechanism of rebound occurs. So once you stop atropine, so it is pretty obvious that not all the effect of atropine is because of its effect on the lens thickness, but yes, there is a possibility that at least some part of it is also because of the changes in lens thickness that occur. Although the changes in lens thickness are very minimal, and it is very difficult to measure the changes in lens thickness measured on even on IL Master 700. We can see that when we compare the data of Saxena et al. Versus Havid et al., Havid Hansen et al., you can see that when both of them were using 0.01%, there's not much of a change. When Havid Hansen started using 0.1%, definitely there was a change, because it is much higher concentration. It is almost 10 times the concentration, and so there was an effect on lens thickness. And once they started using atropine 0.01%, after 6 months, you can see the change reduced from 0.03 to 0.02. So that was regarding how atropine works and what is the current understanding of what theories and what are the real-time situations, scenarios, what is the amount of accommodation when you induce accommodation, what are the changes that occur. These are the things which are currently understood about low concentration atropine in the market. Importantly, Hughes et al. Used 0.025% compared to Saxena et al., who used 0.01% in 2023. So this graph tells you this particular solid line is pre-atropine and this is post-atropine, and you can see that lens thickness is actually reduced and antechamber depth has also reduced. So you can what you can see is this is antechamber depth, and the patient, this is the zero position. Oh, sorry, this is the zero position. And when you induce accommodation of 2 diopter, 4 diopter, or 6 diopters, you can actually see that in dynamics also the lens thickness was changing, and that is clearly my apprehension with the articles or with the numbers of Saxena et al. And Havid Hansen et al. That lens thickness we don't know when they were using to calculate lens thickness how much was the change, because we don't know what was the accommodation stimulus, and it has not been mentioned in their articles whether the patient was kept at a fixed accommodative, whether patient was given any accommodative stimulation or not. So that was truly regarding the biological and the actual physiological mechanisms of low concentration atropine that are currently understood by all of us. So, these, in spite of all these theories, there are still few things which remain unanswered, whether it is truly the muscarinic receptors, or it inhibits actually the choroid, and it actually inhibits the choroidal thinning, or it actually increases the choroidal thickness, which is coming from defocus signals to retina, signals to sclera, or it is directly going towards scleral fibroblasts. Whether there are any long-term side effects or not, there have been, there is a good study. I mean, it is against the fact that atropine works in long term, but it does tell that the Atlas study, which does tell that there are no real long term side effects of low concentration atropine, whether it should be used as drops or as other forms of delivery, whether it can be given directly injected, and what should be the frequency. Now, recently I stumbled upon an article about once a month or once a week dose of atropine 1%. So there are multiple logics, multiple ways of giving atropine, bolus therapy of atropine 1% once a month at the beginning of a month, and then only once after 1 month can be given. And it seems that everything does work, especially when it comes to atropine. So it has, these are really testing times. These are really the time of a lot of unanswered questions. What should be the frequency? We don't know at this point of time. And when I was looking for the current articles, there are more than 400 articles which are published in last 2 years or even more. So it has been extremely difficult to select articles of value out of it, because there is a lot of repetitive information on atropine, and it is very difficult to scan through all the articles and find out what is new in this particular article and whether it is true or not. So with this, all this background in mind, I think I will start with one of the most remarkable studies which was done by Chua et al. In 2006. And I think this was one of the articles which started the whole thought process, the whole point of reinventing atropine, because it was already there in the market. Already there was a lot of literature in the market that atropine works, even low concentration atropine works. So that there was this article, I think, renewed all the interest in atropine. Uh, this particular article had a very good, robust number of 400 Singapore children who were placebo controlled, double masked, and one eye was compared to other eye. So that was also one of the very strong points of this particular study, where atropine 1% eye drops were instilled nightly in one eye over 2 year period, and it reduced myopic progression significantly in children by 77%. So that was a time when we used to calculate reduction in percentages. We no longer calculate that in percentages now, but in direct numbers. So 0.28 diopters in control group versus 1.2 diopter in atropine group. So that was the strong level of control that 1% atropine had. I think with this particular background in mind, they went forward towards finding out lower concentrations. Although 1% was tolerated well, according to the study, there we all know that atropine does have a very strong effect on accommodation and also on photophobia, and it is quite difficult to use atropine 1% in clinical practice. So I think by the end of 2 years, they stopped using atropine, mainly because they found that it was beyond the difference between the two eyes, and making the patients anisometropic was huge. So I think they stopped the trial after 2 years. It was planned only for 2 years, and then came Atom 2, uh, and then came 5-year clinical trial of Atom 2 study. So, what were the key findings of this? So, almost 400 myopic children between 6 to 12 years. So, phase 1 of Atom 2 study was the randomized control trial to receive nightly drops of either 0.5%, 0.1%, or 0.01% atropine in both the eyes. Unlike Atom 1, there was no placebo group. And in fact, there were two things in this particular study. They used the same data of Atom 1 as the baseline placebo group. And also, interestingly, if you see that normally if you dilute the concentration of 1% to 100 times to almost 0.01%, you can actually use 0.01% as a placebo arm. Now, before starting the RCT, they were not really sure that 0.01% will work, and hence there was no placebo group, because 0.01% was, in a way, was thought that this could be used as a placebo group. And phase 2 was a 1-year washout period. All the participants discontinued atropine treatment to assess for rebound effects. And phase 3 was the retreatment group, where children who showed significant myopia progression during the washout period were retreated or re-put or restarted on 0.01%. Now, to the utter surprise of Chia et al., they found that all the three concentrations showed significant efficacy in slowing down the myopia progression. And obviously, they compared it with the historical placebo group of Atom 1. Now you see the power of 0.01%. The 0.01% was no longer now a placebo, because it was actually showing some treatment effect. And at the end of 2 years, the difference in efficacy among three concentrations were very small. So 0.5%, 0.1%, 0.01%, all three of them worked very well, although they did mention that it was a dose dependent, although clinically insignificant effect. And 0.01% showed comparable efficacy compared to the higher concentrations. So the mean change in spherical refraction was 0.049 for 0.01%, 0.38 for 0.1%, and minus 0.30 for 0.05%. So 0.05% atropine did work better than 0.01%, but the changes were not really significant. Axial length changes also showed a similar pattern, but they were not exactly correlating with the refractive power. And most of the effect of 0.01% actually came in the later part of the second year. So those were some of the key findings. Now, after 2 years, and after discontinuing atropine for 1 year washout phase, obviously a rebound effect was observed, and it was about these two important aspects of low concentration atropine. One about axial length not exactly correlating with the glass power, and rebound effect that we do discuss about the changes in lens thickness also, although that also is not a very substantial or substantiated theory at this point of time, because of lack of checking physiologically according to the fact that what exactly was the accommodation at that point of time. So coming back to rebound effect, the rebound effect was significantly less pronounced with 0.01% compared to higher concentrations. So, for instance, 68% of 0.5% group experienced a progression of at least 0.5 diopter during washout, compared to 59% of 0.1% group and only 24% of 0.01% group. So this also shows that, if you try to use a stronger concentration, the chances of rebound would also be stronger. Younger children and those with higher baseline myopia tended to experience a more significant rebound effect compared to those children who were slightly older at the beginning of the treatment. So side effects obviously went down when you compare it with Atom 1. There was hardly any pupillary dilatation and hardly any loss of accommodation, and 0.01% went around with almost a negligible side effect, and bulk of the patients were happy to use 0.01%. And this was for the first time that such a reduced concentration was used for control of myopia and was showing some effect, even when compared with the classical historical placebo group of atom 1. And when you come back to all this goody things that occurred in 5 years, and then there was a the only last year there was a study which was published on atropine treatment for long-term assessment study, the Atlas study, the infamous Atlas study, which included the participants from atom 1 and atom 2, just to assess the outcomes of 10 to 20 years after they have stopped the treatment suggestion. Now, to the surprise of everybody, the long-term follow-ups did indicate that for the proportion of original participants who were available for analysis, the short-term topical atropine use, which was used for 2 to 4 years during childhood, was not associated with significant long-term differences in the refractive error. So at the end of the day, all that atropine which was used, the patient sort of caught up with the myopia progression, or they ended up very similar to each other when they compared it with the patients who were on placebo. So this does suggest that when atropine is definitely effective during active treatment, its long-term impact on final adult refractive error or incidence of myopia complication. Now, because there was not much of a difference in the final refractive error, we cannot really say whether it was very useful to use it at that particular time for reducing the progression of myopia in the final refractive error if the treatment was stopped relatively early. So it also shows that we have to keep on looking at these patients till they are at an age where they stop progressing further. So if we start atropine very early in their life, like at 6 years of age, and by the time they are around 9 or 10 years, we stop giving them atropine, there is a chance that they would end up being myope as they would have otherwise been. So they do need continuous treatment and long-term duration of treatment, whether with atropine or combination therapy or any other therapy. So that was regarding atom 1, atom 2 and Atlas studies, which were actually the long-term follow-up studies of atom 1 and atom 2. So what are the so what came out of this was that there was absolutely minimal or no effect on accommodation of low concentration atropine. Chances of side effects went down. The retardation of progression doesn't seem to be dose dependent and is comparable. So what they are trying to say is that yes, with higher concentration, it does make a difference, but the difference is not really significant, and it is now easily available in our country. Now, then after this came the LAMP study, and why only these two particular studies I have taken for discussion is that these two studies have extensively evaluated the role of different concentrations, and they have done very strong RCTs over a period of a long time. So LAMP study I think they started in 2018 and started publishing from 2019 onwards, and this was LAMP 1, which came with 438 myopic children from between 4 to 12 years. And now when LAMP 1 came, they already knew that there was atropine 0.01%, and it was being compared with 0.5 and 0.1%. And so the beauty of this particular study is they went a notch further, and they tried to see very close concentrations of atropine 0.01, 0.025, 0.05. So when you go back to the original atropine studies, you would see that the concentrations when reduced from 1% were truly arbitrary. So the arbitrary concentrations were from 1%, they went half of that to 0.5%, and then they went almost 1/5 of that to 0.1%, and then 1/10 of that to 0.01%. Whereas once you have established that it will work at a level of 0.01%, you have to start the study with a double of that, that would be 0.025, and double of that would be 0.05. And this particular study did have a placebo arm, unlike atom 2 study. And at the end of 1 year, so LAMP 1 was published at the end of 1 year, they did see that all three concentration of atropine did reduce some myopia, and it was a purely concentration dependent manner. And yes, they did find that although there was a correlation with axial length, but the correlation was not linear, in the sense that the amount of change in spherical equivalent was not directly correlated with the amount of change in axial length. So they did find that with atropine, the progression was much slower, to a tune of minus 0.27 diopters, and with 0.01% it was 0.59 diopter, and with placebo it was 0.81 diopters. In fact, in the first phase of this study, they found that atropine and placebo went almost hand in hand, and there was not a great result from 0.01%, and they felt that 0.025 or 0.05% were much better and had a much stronger control of low concentration of myopia progression control. So the axial length elongation also was quite high in 0.01%. In fact, with our times now, we would say that 0.36 is almost a non-responder, and at the end of 1 year, 0.59 is also a non-responder. So quite a lot of patients would be into a non-responder group. Even in ATOM 2 study also, the second year, they had a better control compared to first year with atropine 0.01%. Now, the take-home message obviously was that 0.05 was much better than 0.025, which was much better than 0.0501, which was slightly better than placebo, and they also found that all the concentrations were well tolerated, and found that 0.05%, 0.02% also had good control and very less side effects. When it comes to side effects, that is what we are looking forward to when we talk about low concentration atropine. So phase two came in, I think, the following year when we were all having COVID. Uh, so in the phase two, at the end of 1 year, due to ethical considerations, all the placebo group patients who were progressing, and there was a notable change. The phase one From phase one, the placebo groups were switched to 0.05%, which was the most effective concentration as per them in their phase one, while the other active group continued their respective regimes. Now, as it happens with all the RCTs and all the long-term studies, there were 383 children from the original LAMP phase 1 study who continued into phase 2 study. And in this particular case, they did find that spherical equivalent progression over 2 years with 0.05% atropine was 0.55, with atropine 0.025 was 0.85, and with atropine 0.01% was minus 1.12 diopters over a period of 2 years. So per year change, if you see, was still more than zero point 0.5 diopters, which is the classical definition. So my point is that a large number of patients will definitely be non-responders to 0.01%, and this also shows, this phase 2 study also showed that 0.01% group showed mild improvement in their efficacy in the second year, as ATOM 2 study also showed, and axial length also did not show much changes, but they were definitely not related to the amount of change. So you are getting more response when we see in terms of spherical equivalent, and not a comparable response when you see in terms of axial length. So yes, the placebo group, after switching to 0.05% concentration, also showed significant reduction in myopia progression over a period of 1 year. Now this what this was all from LAMP 2. They obviously came up with a obvious conclusion that 0.05% were much better drops, and they were the optimal concentration among the studied low concentration, because they found that it was giving a very tighter control. At the same time, the side effects of 0.05% eye drops of atropine were very minimal as per them, even comparable to 0.025 or 0.01%, but the effect was much better. And so they also extended this to phase 3, that was 3 year results, which included the washout periods to assess the rebound when you compare 0.05, 0.025 and 0.01 for rebound. And phase 4, they wanted to see the later phases where there were some patients who were continued on 0.05% even after 2 years, and also to see the rebound phenomena after the cessation of treatment of 3 years or more. So phase 3 report had continued versus washout of low concentration atropine for 3 years. Now, why it is very, very important to discuss about phase 3 report is that it also removes a lot of cobwebs around the fact that whether atropine should be continued only for 2 years, or it can be continued non-stop for 3 years. So a lot of times I also used to say that at this point of time we really don't have data to suggest that we can continue atropine non-stop for 3 years or not. Although our first RCT on atropine was for 3 years, this is one of the strong reports published in 2022 where they did use atropine for 3 years and also compared it with washout cases. Obviously, they felt that 0.05% was the most effective combination with the concentration dependent response. And the key findings was that there was no initial hyperopic shift in any of the atropine groups, which was a previous concern with very high concentration atropine. So once you are using 1% atropine, the problem is that your accommodation will be completely suspended. Also, they did not find any significant differences in vision related quality of life among different atropine concentration when compared with placebo groups. Now comes the most important part, that was the long-term efficacy with low concentration atropine. This particular, the phase 3, the 3-year results, they did provide evidence for the long-term efficacy of low concentration atropine, and they did find that constant or continued usage of low concentration atropine 0.05% did help the patient in reducing the overall progression of myopia. And they did compare and they did found that obviously the rebound was more. All this all this was very nicely put up in atom 2 studies also, where they also found that the rebound was much higher in much more stronger concentrations. So that was in a sense from the phase 3 ones. Most important part of phase 3 report was that you can continue it for a longer time. And in phase 4, uh, so this was a 2-year extension to the initial study, that was lamp 1, and this was published last year. And the study was obviously to determine the proportion of children requiring retreatment. So once you stop, because by that time I think the Atlas study had also come, but they had already planned on doing the study of which patients again progress and they require retreatment, and the efficacy of proraneta treatment with 0.05% atropine. It also investigated the impact of continued versus resumed. So all these children who were requiring retreatment, they compared the two arms of it, and they also found that 0.05% atropine treatment, it did demonstrate good efficacy. And once you stop the treatment at 3 years, you would see that most of the children would require a restart of treatment. So that also emphasizes that these patients are to be followed up for a longer time. And once you restart the treatment, it shows it has a similar efficacy. So I think it gradually goes into the favor of the fact that the atropine treatment can be continued even after 3 years in some of the patients, and in other patients you can obviously go down, stop the treatment, and then again continue it. Keep calling the patient if it is needed. You may restart the treatment with 0.05%. So what they found was that most of the patients do need the treatment. Younger age was the risk factor for retreatment, obviously, because they have more years to grow. So younger children were more likely to require retreatment once you stop atropine, because once you start at a very young age of 4 years, after 3 years the kid is still 7 years, and there is a very high risk that patient would still progress further. So this was they did show that even if you restart the treatment, it shows equal efficacy compared to the previous ones. And it so obviously what was highlighted and was known was that you have to keep on monitoring the patient, you have to keep on individualizing the treatment. If the patient comes, you stop the treatment after 3 years, and you keep on monitoring whether the axial growth is still there and how much is the rebound, and you can restart the treatment. So I think LAMP 3 and LAMP 4, at least in terms of stopping and restarting the treatment, they have done good work. They have shown what which was already thought to be true. They have already proved that it is important to keep on monitoring these children over and over again, and to be sure that they are not progressing further. And if they progress further, you have to restart the treatment. So whether it uh, now this was published long back in 2021, where they showed that the risk of the treatment response completely depends on the age. Younger age is associated with poor treatment response, and I think ATOM 1 and 2 also showed that younger age, parental myopia, uh, these are the two important risk factors, and high myopia. If the treatment, if when you start the treatment, if patient has a myopia of more than 6 diopters, it is less likely that that particular patient will be a good responder. So high myopia at the beginning, younger age at the beginning, and parental myopia were three things which were shown by ATOM 1 and 2, and also by LAMP, that these will show poor treatment response to low concentration atropine at any concentration. Now we did talk about in 2023 and 25 about lens thickness, but this was just before that in 2020. They did show that it had absolutely no effect on on the lens power, on the corneal curvature, and corneal curvature, axial length, antechamber depth. Only the axial length was affected, and they felt that ocular biometer parameters were comparable among the groups, and they did not feel that astigmatism, lens power, anything was changed after even lens power. They did talk about lens power decreased over time in each concentration, but its changes were also similar across all concentrations. So they did not feel that there was much of a change in antechamber depth among us the groups. And but this was also way back in 2020. So there was some work done in 2023 and 25 which does suggest that there was indeed some change in lens thickness. So that was all about whatever is known on atropine 0.01%, 0.05%, and the articles of relevance. So where does all this data, what does it tell? What it tells is that atropine eye drops do reduce the progression of myopia. It is beyond any skepticism, beyond any doubt, that atropine eye drops do work. So the next step comes to what about the concentration? So the concentration, it is definitely concentration dependent. At least with all the new reports, it is now known that if you increase the concentration, the effect of atropine does increase. Whether 0.01% holds any value or not, of course it holds a value. The first and foremost thing is, at this point of time in our country, we only have 0.01% available. So the concentration of 0.01% at this point of time does hold value. That is the least invasive or least possible concentration of atropine available. Uh, will the increase of concentration help in non-responders? Well, we did our own work, and we had presented that 3 years back at AIOS, showing that increase of concentration does result in response. There has been at least one article where they have suggested that if the power is increasing much more rapidly, up to 0.75 diopters, they can be put on atropine 0.05%. That is from RP Center. And so I will show you the data where we have talked about how an increase in concentration or increase in frequency does work in non-responders. So this was our work, which was presented at AIOS 2018, and we got the Best Paper Award for this. And this was a RCT which we did in 2018. This was a PG thesis of one of my students, Dr. Sanket, and all this data was collected by him, and we could find that there was definitely a reduction in control versus atropine group. And atropine progression, as you can see, that with atropine, the curve was definitely going down. This was way back in 2018. The data was from there. It talks about axial length, the change in axial length at 1 year, and it also talks about the changes in the dioptric power. So, uh, another important work, I think this is one of the very important work and very least very least studied subject in atropine, and that is compliance in usage of low concentration atropine. Devanshi was part of this particular work, and so this particular work we could actually prove that compliance is very important. And whenever it comes to a study, or whenever it comes to work of putting atropine eye drops or putting drops for a very long time, it is very important to look at compliance. And I think bulk of the patients only out of compliance do not respond to atropine. That is what I feel, that a lot of patients on atropine do not respond mainly because they are not putting drops. And we felt that at the end of 6 months, the initial four who did not start the drops could not continue regularly. So that is almost 15% of the patients did not comply. And this is only a very small sample size and a very small, very small follow-up. But even with that small follow-up, at the end of 6 months, so 6 months is a pretty small follow-up when we talk about 3 years. The initial four did not continue regularly, and I don't know how many would forget to put atropine once we continue it for a very long time. So atropine is a wonderful drug. I think delivery system at this point of time, and that is why I think they have come up with atropine 1% once a month, because compliance is a serious issue, serious, uh, undiscussed, or I would say rather unthought of issue, because not many people think about what would be the compliance, because whether patient is putting the drops or not. And that is what is the most important point when it comes to the results, when it comes to evaluating the results of what is happening with these particular drops. So we did some work on effect of twice a day usage in non-responders to low concentration atropine. This was an interesting study. Part of this particular work we presented at AIOS. I think it was in 2023. But then since 2023, I started my PhD in 2022, and we have good number of patients who are non-responders and who are progressing more than zero point 0.5 diopter despite being on atropine 0.01% once at night. And the compliance was good. As per patient's parents, the mean axial length was 23.61, and it was definitely, the axial length was also progressing. Lo and behold, it was progressing 0.32 millimeters. And the although the progression in terms of dioptric power was 0.67 diopter per year. And once we started this, the children who did respond showed the progression reduced to 0.36 diopter per year. And still only 40% of the children did respond to twice a day atropine. And some of these children who did not respond were switched over to higher concentration of 0.05. I'm sorry, there's a mistake of 0.5%. It is 0.05% atropine drops. And the effect of these 0.05% atropine eye drops on non-responders, we did not publish it, but we have presented it at some of the meetings. And we had children who were not responding to atropine, and we could convince them to put it on 0.05%. And the children who could tolerate were continued. And 8 children did complain of difficulty in near vision and also of photophobia. So I think the number of children who on 0.05% who could tolerate it are definitely less than 0.01%. And I don't agree with the lamp trials that 0.05 is as tolerable as 0.01%. 0.05% definitely has less compliance in terms of the side effects of difficulty in near vision and photophobia. I have not included the data of NPA and NPC which we did with Devanshi, but we did have at least 8 children who stopped using 0.05%. especially because they complain of difficulty in near vision and on of photophobia. But we had very good response in these non-responders of almost 46.3% patients or children responding to 0.05%, and the progression reduced to 0.024 per year compared to 0.71 diopter before that, and the axial length change also reduced quite significantly per year. So this was just to highlight the importance of putting atropine 0.01% drop twice a day, or sending them or changing them to 0.05% eye drops, or increasing the concentration of eye drops. I think both of them work. There is no work across the globe on twice a day usage of 0.01%. We did present it at AIUS, and we think that it has got very good importance, or uh, very good results when you use it twice a day compared to once a day. So in some of the patients where we see that they are progressing much faster, and if they are not really tolerant to 0.05%, they can be definitely put on 0.01% eye drops, and it does show response to the twice a day consideration versus once a day concentration. I think that we did a extensive thought process, extensive talk on pre-myopes. This is the same study which we presented in AIUS and also published in IGO, where we showed that atropine 0.01% does work in these pre-myopes, and all these pre-myopes did have they had a tendency to increase towards myopia, and only those patients were included in this particular group. We did use low concentration atropine in post-op pediatric cataract patients. I know there has not been any data or any such report across the globe on using atropine 0.01% in children who have been showing myopic shift, and not many patients, but yes, over a period of time we have these 7 patients. I have the data of these 7 patients, but I think we have more patients, and we have sent it for publication in ophthalmology. But these patients, if you look at the data, this is the data only till 2019. We have the data, but this was a chart we made for a presentation on pediatric cataract and atropine being used in these patients. We did some work on how atropine started affecting. Pre-atropine, the absolute growth was 1.16 millimeter per year, and the rate of axial growth was 5.15, whereas post-atropine it came down to 1.76. So atropine does work even in absence of a phakic lens. So not all effect of atropine comes on accommodation. So this also proves that atropine can be used in absence of lens, in absence of accommodation. And we continued this drop for 3 years because there were absolutely no side effects. And by the time the kids start growing up a lot, all these drops were started only after 4 to 5 years of age, not before that. And this was the changing the rate of axial growth to yearly change. You can see this is about the axial length, and this is about the dioptric. You can see how it is flattened out compared to what it was before. Now there are a lot of questions on the long-term safety, and whether these drops are safe at all. So we did some work on pattern ERG to show that in adults with low concentration atropine, one of that adult was myself, and one of the 2 other adults were my own clinic staff, where we used low concentration atropine in our own eyes, and we did pattern ERG and showed that there was no change in pattern ERG. So atropine was not really affecting the retina or anything like that. We also did higher order aberrations in low concentration atropine, and we showed that at the end of 1 year, there were not much difference or much change. Yes, there have been 3 cases reported of children who were operated for exotropia, went into esophoria to esotropia, and this was reported by Mihir in 2020. Allergy to atropine, we have not seen many. Out of 600, I think we have seen one or maybe two patients. So this has not really been published, but we did not see much. Pupil size change in that particular work which we did for 3 years, it was 0.8 millimeter at the end of 1 year. But we have data for pupil size. It is not really significant, and near point of accommodation also does not change much, at least in 0.01%. In 0.05%, yes, it does make a lot of difference, at least in some of the patients. Now the question, all this findings, all this thought process boils down to the single slide, single thought process, single question: how and when to start low concentration atropine. So first and foremost, we have already seen in a couple of lectures that we have to document vision, cycloplegic refraction, keratometry, and axial length, and we have to record axial progression. If there is no axial elongation, if there is no axial progression, we at least as doctors cannot start atropine. Now, twice works better than once. So in some of the patients where I see that patient is progressing much faster, I would put them on twice a day rather than once a day, and would look for any side effects and then try to taper it after 2 years. Maybe I may do it once a day. So there are no fixed combinations. Everybody has its own way. Some people start using atropine 0.01%. If the kid is already on once a day, they would try to taper it alternate days for 3 months, and then once a week for 3 months. Some people, if it is already on twice a day, would taper it like for a month once a day, and then alternate day for another month, and then once a week for another month, and then they will stop. So at least for 2 years, yes. And after lamp, I have started using it at least for 3 years. I already used it for at least 3 years, but did not have the, on a scientific platform, it is difficult to say that you can use it constantly for 3 years or more. There is no upper age. You can use it till 16 years of age. So there should not be any confusion. The lower age is normally 4 to 5 years, mainly because you have not recorded any progression before that. It is very difficult to record axial length under 4 years of age. Always look for non-responders, be critical, always measure axial length, always measure cycloplegic refraction, and look for non-responders, and start stepping up atropine. I think in coming months, Antod and even Sun Pharma will come up with 0.025% and 0.05%. So we will have those combinations also when we have these non-responders. Younger children, parental myopia, higher myopic power at the beginning are very, very strong risk factors that these children would be non-responders. So you can start them on combination therapy. And we will also talk about what are the combination therapies which are available in next lectures. Progression is different in different age groups. So if you are looking at a child who is 6 years old, may have a different level of progression compared to somebody who has hit the menarche, or somebody who is at 15 years of age. So you can tweak the doses. There are no fixed rules for low concentration atropine at this point of time, but yes, you can start thinking of tapering it once you feel that there has not been any significant progression for at least 6 months to 1 year. So those are some of the tips which we can think about low concentration atropine eye drops. Non-responders is indeed a reality. So if you go back by charts, you will see that even in LAMP, or even in most of these studies, you will see that almost 30%, 48%, and 56.2, almost 50% of 0.01% did not progress by more than 0.5 diopters. So non-responders are a reality. If you see non-responders to 0.01%, 18 to 28% will continue to progress beyond 1 diopter. So these are actually super non-responders rather than just being non-responders. So keep looking out at non-responders, and don't be afraid to say that this particular patient is a non-responder and switching over to higher concentration. So it is very, very important that you should be looking out at non-responders despite being compliant. And I think a lot of patients in this would also be non-compliant to putting atropine constantly. So after all that, still we have to understand that environmental modifications do hold the key to stopping the progression of myopia. Even if patient is given atropine, even if patient has been on combination therapy, we should always overemphasize the fact that near work, outdoor activities are a very strong precursor towards myopia control. So we have to tell the patient not to do near work. We have to tell the patient to sit outdoors, reduce indoor work. I think this was an exhaustive lecture. A lot of details. I know there are still a lot of unanswered questions. We will meet on Zoom and we can discuss them further. Thank you so much.